So good morning, everyone. I would like to thank you, the organizing committee, for inviting me to speak in this wonderful meeting today. So my job today is to try to convince everybody that curative approach should be the way to go for the treatment of CML nowadays and in the future. This slide shows the characteristic of the CML patients in the study Asian countries compared with the Westerns. And as you could see, from this slide, our CML patients are much younger than the patients from Western country. If we combine the data all together, the median age of CML patients in Asia is approximately 45 years. So they are about 20 years younger than the patients from Western countries. Since our patients are 20 years younger, if they are started on the TKI at the diagnosis, they will be on this medication for a really, really long time. The problem with the NIPS forever. Number one, financial burden. This is a recent study which demonstrated the increased financial burden among patients with CML taking imatinib in Japan. More than 500 patients completed the questionnaires in Japan, and the financial burden was felt by 41.2% of the patients treated with imatinib in 2000. The number and the ratio has risen to 70.8% of the patients treated with imatinib in 2005, and in 2008, a financial burden was felt by 75% of the patients taking this medication. About 30% of the patients consider the discontinuation of the drug because of the financial burden. Older patients and patients with higher incomes, they wouldn't have any problem, but the younger patients and the patient with lower income and the patient who has to pay for co-payment, high co-payment, were more likely to have considered discontinuing this medication. So the conclusion from this paper is that financial support for patients treated with expensive drugs remains a major problem even in Japan. Second problem, the off-target side effect. Though these inhibitors were developed for the treatment of CML, they are not entirely BCR-ABL specific. This lack of specificity can cause off-target side effect, especially with a newer agent that we don't know if we use long-term what is going to happen, and also for our younger patients, in children and also in young Asian patients that has to take the medication for a long time. So these are the examples of the potential off-target adverse effects, which sometimes were not initially reported in the clinical trials, but reported a few years or years later. Recently, there have been a few reports of the impact of imatinib on skeletal growth in children and bone health in general. A few reports show that children who were on imatinib had lower height compared to normal children. Some patients who take imatinib for a long time may have secondary hyperparathyroidism. Thyroid dysfunction caused by new generation of TKI also has been reported in TKI, both in solid tumor and also in CML. And we also are dealing with our younger patient who want to get pregnant. So as we all know, imatinib is teratogenic and it should be avoided in the patient who wants to get pregnant. There was a few reports of oligospermia and gynecomastia in male who take this medication for a long time. And recently, they also report in a vascular event in older patients who take nilotinib. Some of the patients develop peripheral arterial occlusive disease. There are also some reports of precapillary pulmonary arterial hypertension in the patient treated by dasatinib. And also platelet dysfunction that we all sometimes can see our patient has a breathing problem for the patient who take dasatinib and imatinib. So we have to be very careful monitoring this unusual new side effect in the patient who are on long-term TKI treatment. The third problem, compliance. Adherence in the patient who need to be on chronic oral therapy forever. The adherence is going to be the issue. In several studies of the patients who were on imatinib for some years, the non-adherence rate were reported about 30% of the patients. In one study, it showed that to have a very good molecular response, the adherence of the patient need to be more than 90%. Other reports also show that poor adherence can also cause increased healthcare costs. And in a study from India, it may even reduce the event-free survival in the patient who is not really compliant to the medication. So to have a really good response, the patient needs to be adhere to the medication more than 90%. Another problem of TKI treatment of CML in Asian patients comes from this most recent interesting report from Singapore published in Nature Medicine. This study showed that genetic variation or genetic polymorphism can affect the patient response to the TKI. This genetic variation, specifically we call BIM deletion polymorphism, is only found in East Asian people. CML patients who had BIM deletion polymorphism has experienced significantly inferior response compared to the patients who had no this polymorphism. And to compare these two cohorts, the odds ratio for the resistant disease in the people who has this BIM deletion polymorphism was 2.94 with a p-value of 0.02. And the majority of these patients, when they go to the second generation TKI, the majority of these patients also resistant to the TKI treatment. So what is BIM? BIM is a apoptotic member of the BCL2 family of protein, and it is required for TKI to induce apoptosis. So it will be affect all the TKI-driven cancer like CML or even the lung cancer. The polymorphism switched BIM splicing from exon 4 to exon 3, which resulted in an abnormal transcript that produced a truncated and inactive BIM protein, causing intrinsic TKI primary drug resistance. So with all the problems that I have mentioned, I think curative approach is the way to go, either using transplant approach or non-transplant approach using the drug, but we have to stop it. We cannot use it forever. The first approach is transplant. Allotransplant, as everybody knows, is the only curative treatment of CML, and the long-term outcome of transplant nowadays is significantly much better compared to the report in the past. This has been shown in several studies, including this data from Hammersmith Hospital, which show that the long-term survival of 80% with modern transplant compared to like the 40, 50, 60% of survival in the old transplant. So nowadays, transplant is much better. With the recent improvement of an outcome of stem cell transplant, it may even become preferred treatment option in countries with limited resources, as demonstrated in this report from Mexico. This report showed that the outcome of modern transplant in this report, reduced intensity allogenic transplant, was similar to the TKI in the freedom from progression and overall survival. So the author conclude in this study, in Mexico, cost consideration favor allogenic stem cell transplant as a once-only procedure, whereas lifelong treatment with an expensive drug represent an excessive burden on resources. At my institute, the cost of one single allogenic stem cell transplant is about equal to 6 months of TKI treatment. So everybody could figure out if the patient needs to be on this TKI for a really, really long time, how much it's going to cost. So for non-transplant approach, as everybody know that the medication need to be stopped. I mean, the patient wants it to be stopped. So this report also showed that in some patients who maintain CMR after stopping imatinib, about 40% of the patient can maintain CMR. And with the newer generation TKI, which have superior efficacy in helping the patient to achieve CMR, more patients may be able to discontinue the drugs. So the theory is to use better drugs initially to reach CMR with the goal to stop TKI later. This concept is now being tested in several clinical trials. And lastly, residual leukemia cells can be detected in the patient who maintain even a CMR after stopping imatinib by using a very high sensitive DNR-PCR technique. And the reason for this is because of the few quiescent stem cells, leukemic stem cells, that are usually resistant to TKI treatment. So nowadays, several strategies to eradicate these leukemic stem cells show promise in preclinical studies, and a lot of agents are being explored in clinical trials. There are agents target leukemic stem cell survival and or self-renewal pathway, JAK2, PP2A, MCL1, ALOX5, SDAC inhibitor, SIRT1, autophagy inhibitor, and agents to try to disrupt hedgehog pathway using small inhibitor, windcatenin signaling pathway, CXCR4, by using immune targeting the leukemic stem cell using antibody, and by using the agent to mobilize primitive stem cell or quiescent stem cell into the cell cycle, such as using interferon together with TKI. So there are hope to cure this patient. So the success of CML treatment nowadays has changed a deadly disease into chronic disease. But we should not stop and satisfy only this. We still need to make progress with today's goal of trying to cure this chronic disease. Thank you for your attention, and please cheer me for the cure.
Thank you very much. Please come here. Now, this debate is open for discussion, of course, and Professor Champlin.
So imatinib is going to go off patent sometime soon in the next few years, which will likely change then the economics of TKI treatment and may well impact the issues in developing countries if it's going to be a much cheaper drug, because clearly the toxicities of imatinib is much less than the risks of chronic graft-versus-host disease or transplant-related complications. So if it was an economic argument, that at least will improve that.
Thank you. Are there, please, Professor?
So in CML chronic phase, who received imatinib and then get the MMR, if we change to second-line TKI,
Who wants to
going
respond? This is a very important question, of course. Professor Tang?
So you mean
for those who have already in major molecular response, but you wanted to probably achieve MR 4.5 and to try to discontinue, it's worth it just to switch to second generation TKI?
I guess there is no existing data for MMR patient with imatinib and switch to second generation TKI to get a CMR.
There are very few data of the CMR, so-called CMR trial done by Australia and also in Asia and South America, and they are showing that there is a higher percentage of MR 4.5. But we do not know if this really corresponds to a higher probability of discontinuing the treatment without. So it's too early to answer to your question. Of course, it's a very, very important point, of course, to be addressed. Are there other questions? Just a comment on my side is I think that your presentation were extremely good, both of them. But rather than a debate, they were really a sort of, there was a really convergence of different opinions, because we are certainly facing now a moment in which we are changing, I would say, our approach to CML therapy. We are moving, we want not only to control the disease, because this is expensive in terms of, from the economic point of view, but also in terms also toxicity, and many aspects of the toxicity at the moment are not, we want really a curative approach. What we really do not know in terms of cure, that we know as a proof of concept is possible also with TKI, which is the extent of this curative approach that we can achieve in a reasonable period of time in CML patients with imatinib first, but then also with second generation, maybe with third generation TKI. But I think that we are really facing a change in the control, and simply control, unless that we are really focusing on specific patients with other problems, maybe elderly patients, maybe patients with many comorbidities and so on, is no more acceptable, particularly in Asia, where, as you have shown, we have a very, very young population, and so it's probably we are facing a very long period of treatment if we simply aim to control the disease rather than to be curative. Would you like to comment on this?
Yeah, I agree. And if our treatment goal is the curative intent, then that becomes a real debate. We either choose transplant to get a cure, or using a TKI to get a cure. That will be really a challenge for these two parts. Yeah,
absolutely.
I agree. If the long-term data show that there are some patients who can be cured by the medication, and the medication can be stopped in the future, I think transplantation will be probably out of options.
Okay.
Yeah.
Please.
Thank you very much. It was very, very enjoyable presentations. Both of them were very good. The two issues about the age, because we have about almost 18 to 20 years younger population in Asia. So apart from longevity, do you have any other thoughts what could be the reason why we have such a young population? Or is it just the population pyramid which in the Asia which we have?
I don't know. We don't know, but I don't know if Dr. Tang know the reason why CML in patient in Asia younger. Why? What is the reason?
I don't have any exploration. Yes, it's at least 10 years younger than Western countries.
Right.
Yes.
And second issue are the economics. Like in India, we have a lot of generic brands available. So there's some experience generated, published also. It seems to be almost similar kind of results experienced by the original molecule. Do you have any experience in other countries apart from India, like any experience with the generic brands? With the same experience or different?
Generic imatinib.
Generic drugs?
Yeah.
We don't have a generic drug in Taiwan, so maybe...
South America, Turkey, and India, of course, are the main.
Yeah. I only have a few patients who are on generic Indian drugs. For other countries, I don't have experience.
Okay.
And my patient who's on the generic branch, also generic drugs, also respond to the drugs.
Okay.
Morning. I would provocatively suggest that the data that was presented regarding the 3-month response above or below 10% is probably one of the biologically most important pieces of data that we have evolving in newly diagnosed CML. Do you think that will become a watershed event to help us decide what to do next with these patients, because it primarily is the biology speaking to us?
Absolutely. Who wants to answer? I think that you are perfectly right. I will develop a little bit these concepts later on in the debate with Professor Champlin, because this is just underlining something which is different from the basic point of view, probably corresponds, in my opinion at least, although we do not have proof of this, to a different expansion of the so-called stem cells or progenitor cell population. And therefore, probably for these patients, which have a higher risk of progression, but also a very, very low probability, almost absent probability of achieving later on a cure of the disease, probably we have to really consider the option of the transplant, in waiting probably also for additional or combination therapy able, however. So I totally agree with you, and this is something in which in the future we will have to address. Are there other questions? If not, I think that we have exhausted our time, and then we can move to the coffee break and reconvene here. No, there is another debate, sorry. Another debate. We missed the point.